Hi, I'm Jack Cush with Room Now. We're here in the office of Dr. Ken Saag, Chief of Rheumatology at the University of Alabama, Birmingham. And I've asked Dr. Saag to join us to talk about this new recipe trial. So the recipe trial is aimed at treating patients with refractory gout with pegloticase and trying to use a DMARD as a way of suppressing the anti-drug antibodies. The PEG is very immunogenic. It's kind of limited some of the efficacy and added to some of the toxicity associated with pegloticase. This has refrained a lot of people from using it. So there have been trials so far, maybe using azathioprine or methotrexate, and then mycophenolate. And then Dr. Saag stepped in and he designed this recipe trial wherein he chose mycophenolate. Ken, why did you choose mycophenolate?
Yeah. Well, Jack, thanks for the opportunity to talk about the study we refer to as recipe. And as you've noted, there's been a fair bit of work previously, mostly observational and somewhat anecdotal, looking at different immunomodulatory drugs to try to attenuate the immunogenicity of pegloticase, which, as you pointed out, is really the limiting factor in using this otherwise highly efficacious therapy. We talked to rheumatologists and we talked to immunologists, and we said, well, what do you see as sort of the pros and cons of different immunomodulatory drugs? And there's, definitely pros and cons of mycophenolate, of methotrexate, of azathioprine. There is a large study underway looking at methotrexate, and I think that will be very interesting, and some preliminary data has already been presented for that. We had some concern that methotrexate, a lot of the patients that we're thinking about treating have had non-alcoholic steatohepatitis, some drink alcohol. Methotrexate requires some gradual increase in dose. And so there was some, potential safety concern about methotrexate, although arguably a drug that we're more familiar with and that we use in combination with our biologics in, the inflammatory arthropathies, RA, spondyloarthritis, et cetera. So we thought that MMF, had a lot of potential, and rheumatologists are familiar with using it. We have a lot of confidence and comfort using it based on our experience in lupus and vasculitis in particular.
So it seems to be a good choice. It was a head-to-head of everybody getting pegloticase, and then half the group got the mycophenolate, and the other half got placebo. The primary endpoint was 16 weeks?
Primary endpoint was at 12 weeks.
12 weeks.
And then we followed patients off the either placebo or off MMF for an additional 12 weeks to see about the durability, whether if you use an immunomodulatory drug for a short period of time, would you sustain durability? Now, keep in mind, this is really a preliminary study. It was largely designed as a pilot study, and while it turns out that the difference between MMF and placebo was statistically significant, frankly, we're a little bit surprised with such a small study design that we were able to observe that.
Yeah, in the short term, really impressive results. 86% on mycophenolate achieved a uric acid less than 6 versus only 40% that were on the placebo. And then you follow them all going forward off the mycophenolate, and it'll be interesting to see how they do. I always thought that the benefit of this kind of trial would be really at long-term outcomes and safety kind of stuff, which seems that there's already a benefit on that in the short term. But talk about both the efficacy and safety from your view.
Sure. Yeah, well, I mean, the key with pegloticase is getting more of it. It works proportionate to how much you take. So I always tell patients, if you get 1 or 2 doses of this, that's better than nothing. But we'd really like to treat people for, up to 6 months or so with this sort of, we see it as a debulking therapy. Somebody comes in, almost all these people in the study, and probably the experienced rheumatologist as well, is they nearly all have tophi. And so we're really trying to, reduce the tophi burden often and trying to treat people who have failed other therapies. And so these are really a difficult group of refractory patients. And so if you can get them on a longer course of pegloticase, you may benefit them more. And clearly 12 weeks is the starting point. You'd like to use it longer, but if 80+% of them can continue it that long, it's a good start.
I think this kind of data should change some of the impressions and move the hearts and minds to look into this, because this is not just a debulking on those really horrific tophaceous people. You know, there are people that are going to benefit from this because uric acid, this is a uric acid deposition disease and does lots of damage. So again, congratulations on what I think is a really impressive result. What's the end point? I mean, this is going to go on for
Yeah, this study is concluded, and again, there's another study looking at methotrexate that you should stay tuned for. I think that'll be very interesting. But I suspect that over time, perhaps sooner rather than later, we may be moving towards using concomitant immunomodulatory drugs with pegloticase, particularly in people, younger people, perhaps people with significant obesity, people that we know from some of the observational data seem to be at higher risk of developing immunogenicity. And we're going to really need to figure out who to consider this in. But it's nice to see an RCT that actually starts to provide the answer to that important question.
Ken, congratulations to you and your investigators and Dr. Khanna, the lead author on this.
I think it's really a great team approach, and appreciate Pooja Khanna being the lead on this, and collaboration between UAB and Michigan with support from NIAMS as well as Horizon Pharma. So thanks to everybody and to all our patients who participated.
Go back to work. There's more to do at the meeting, right?
That's right. Enjoy ACR.
All right. Bye-bye.
Thanks, Jack.